Hi YouTube, thanks for tuning in to my channel called Stories with Lonnie. I am Lonnie, and today I want to talk about a day in the life of a clinical medical assistant. I have a certification to become, a clinical medical assistant. I recently had a job as a clinical medical assistant, and I did it for a few months, but I just really didn't like the way the company that I was at, the way that things were ran, and I didn't like how I was doing the job of two people and only getting paid the price of one. It just wasn't right. So I left. But I still have the certification, and I'm still debating on if I'm going to continue to, pursue that type of career. This is just my experience at the office that I was at. So the office I was at was a gastroenterologist office, so that's dealing with the digestive system. So every day was basically different, but you basically did most of the same things. And depending on if the doctor was there or not, that would be when it would be different. Because if the doctor's there, we were seeing patients every 15 minutes, so throughout the entire day, besides your lunch break, you're constantly seeing patients. So when you're seeing patients, what you're doing is you're creating an intake interview, which basically asks things like if they're a new patient, if they're an established patient, their chief of complaint, so why they are there, if it's for abdominal pain or nausea, vomiting, they're there for a colonoscopy screening, like if they just turned 50, or if they have a family history of polyps, just different things, that they could be there for, or they could be there for multiple things. Then there would also be questions about medical history, what type of medicine that they're on, there's like a review of systems sheet that goes over the different systems in the body, and it asks them to check any of those those things if they've had them for like 2 weeks or longer, or which I think it should have really been like if you've had these issues within the last 2 weeks of your visit, but that's here or there. I don't work there anymore, so I don't really care. But anyways, so I would go ahead and I would call the patient back. Then some of the things I would already have pre-filled out before I brought them back. When I did bring them back, then I would get their weight, I would get their blood pressure, pulse, and I think height, and then I would start asking them more in detail for what the reason was for their visit. So if it was for abdominal pain, then I would want to know what part of the abdomen was hurting, how long has it been going on for, describe the type of pain. Is it sharp, stabbing, burning? Did they notice that the pain occurred more often when they did a specific thing, or if they ate anything specific? And then just continue to probe them with questions like that, depending on what they were there for would depend on the questions, but for the main part, that was mainly the main questions you would ask. Then you would ask about family history. You'd ask about social history. Are they smokers? Do they drink alcohol? Their caffeine intake. Then after that, you would room them, put them in a room, then you would grab your next patient. So the only bad thing about that is like if you got behind, like let's say one of the patients they took longer on filling out paperwork. So if their appointment was at 10 o'clock and they didn't finish their paperwork till 10:15, then guess what? You're already a patient behind. Then once you get them back, who's to say that they filled out all the information on the paperwork, so then you're having to ask more questions, or they might be a patient that likes to talk more, so that could take up another 15 minutes. So now you're two patients behind, so once you get behind, it's hard to catch up, especially when you are seeing patients within that amount of time. That's basically all that I would do when the doctor was there. I would still, like, in between, if I had a few moments, then I would also be answering phone calls, trying to assist patients. Most of the time they would call about medication. Either they were just prescribed a new medication, but their pharmacy didn't receive it, or for some reason their insurance didn't cover it. So then I would need to do a prior authorization on it, or I would have to see if the doctor could prescribe something else to, that is cheaper for that insurance company. And still try to room the patients. So then on the days that the doctor wasn't there, then that's when I would actually go ahead and figure out exactly about those prior authorizations. Like, so who hasn't had them started yet? Which ones have I started, but I'm still waiting on an answer, because it could take, depending on the insurance place, depending on how you're doing the prior authorizations. You could do them over the phone. You could do them, some of them you could do them online. So depending on that, then that would also depend on the response time. Some would tell you instantly online. Sometimes it would tell you instantly over the phone. Other times you would have to wait a few days. Then not only was I doing prior authorizations, but I was also dealing with patients who had Crohn's disease. So they might be on a biologic. So that means that they get injections. Most of the patients were coming from that specific doctor's old office. I was having to treat most of these patients like new patients because they were new to that office, since it was a different company. So all the paperwork, all the injections, even if they were already on biologics, I would have to redo all the forms and treat them as if they were a new patient. So it was just like a lot of legwork. And then on top of doing the prior authorizations, on top of doing the biologics, my doctor would also have results that he would want me to give based off of lab work, blood that was drawn. It could have been based off of a procedure that was done, whether it was a colonoscopy or endoscopy. Could have been results to an x-ray. I would have to call these patients and explain to them their results. If they didn't understand the results still after explaining it to them, or if they had other questions, then I would have to relay that through a message to the doctor to let him know what the question was. Then he would relay the answer back to me. Then I would have to call them and explain that to them. If they at that point had another question related to medicine or something else, or they still didn't understand, then I would have to create another message and relay that back. So it's just, again, being the middleman, and going back and forth with them, letting them know that. And then some of those inbox messages, they wouldn't be related to results. Sometimes they would be recall dates, like, I want to see the patient back in a year to check on this biologic that they just started. So I want to make sure that everything's working fine for them. Or they had a colonoscopy and they didn't have any polyps, so then I want to see them back in 10 years. So then I'm just putting in these recall dates. Maybe they did find a polyp and it was precancerous, so then I'm letting them know that, the doctor wants to see you back every 3 years. So just different things like that. Most of it did require me to call. So if let's say I have 50 to 60 inbox messages, and I have to, most of them, let's say 40 of them, I have to actually call people, then you would think, I say it probably takes between 3 to 5 minutes. That's like half of my day right there gone, or the whole day, just gone just like that. So yeah, but you're going to be doing a lot of those things. Then let's see what else. I'm trying to think. You would do, a lot of pharmaceutical reps would stop by because they want the office to use their medication that they have. So they would want to sit down and speak to you about the program that they have with their medicine, what the medicine's used for. The reps are all really nice, and they usually brought food or brought something, for you having to sit there and listen, so So, nothing wrong on their end, but let's say, if my husband came to visit me, then sometimes, you know, I wouldn't be able to always have the full time with him, the full 30 minutes with him, or, you know, things like that because of all those rep sit downs that I would have to do. So, it was a lot of those. If patients renew, you're creating charts for them. If they are established but they don't have the correct insurance or the changed insurance, or they need to update their pharmacy, you're entering in that type of information. If you're seeing a patient that day, and at the end of the day, which you have to close out each chart, or each, for each patient that you saw for that day. So you're reconciling the medication, you're like looking over everything, because it's very important to be detail oriented when it comes to that job, because you want to make sure you have the right information. You want to make sure that you're in the right person's chart. So you're verifying the date of birth, verifying the name, and then you're checking voicemails. The calls aren't only for you, so you might have other medical assistants that are working with you that you might have to relay voicemail messages to as well, or you need to relay, like someone's calling for that specific medical assistance, and then you're also doing that. Pharmacies calling because they want to do a prior authorization right then and there that you might have to do, or maybe the signature on the medication wasn't correct and it needs to match the amount of quantity, or anything like that, or they just need a refill. So then you're handling that, and also doing like chart abstraction. So when you do have these new patients that have had previous gastro a previous gastro history, then you're having to take all that information from their old office, transfer it, and distribute it out depending on what type of document it is. You're abstracting it and placing it into each category of their chart. And some of them, if they've been, with that doctor for 10 years or more, they have like 500 or 300. They have hundreds of pages that you're having to individually go into and connect them to different categories. So, most of the things that you do, it's not difficult, but the thing is that when you are doing it all by yourself and you have so many patients, then it becomes overwhelming, So I feel like that was my issue, because I felt like, I was getting help here and there, but it was like halfway help, like it was like, I'll do a piece of it for you, but then you're still gonna have to fax this or do that or do this. So then it's like, what was the point of even helping me if you weren't really gonna do it all the way? But so it became too much for me. I will say that was, since I no longer work there anymore, that was a day in the life of a clinical medical assistant, certified.